Hello everyone, welcome to the Journal Club. This is the second in the series for 2019. Today's topic is antimicrobial stewardship principles in the management of COPD, C. diff, and tick-borne illnesses. My name is Annie Allen and I am the Clinical Quality Improvement Advisor at the Wisconsin Hospital Association. I will be coordinating today's event. For those of you not familiar with this technology, we are using a web-based video conferencing platform called Zoom. As of now, all of your mics are muted and all of your video feeds are active. So if you have a camera attached, it's on. Even though there are a lot of people present today, this is meant to be an interactive event and we encourage questions. If you have a question, please type it into the chat box at any time throughout the webinar. Those participating in the live session, and only in the live session, have the ability to earn a continuing medical education or CME credit. After the event, I will send you all a document containing instructions to claim your certificate. One note, the portal will be active starting right after this event and will close on August 22nd at 10:59 p.m. You cannot do it after that, and we can't help you if you miss the deadline. This event is being recorded and a link will be made available to you. So let me now go ahead and introduce you to your facilitator for today, Dr. Bobby Redwood. Bobby Redwood is a graduate of the Rush University School of Medicine in Chicago and the University of Wisconsin Emergency Medicine and Preventative Residencies. He works full-time as an emergency and preventative medicine physician at Divine Savior Hospital in Portage, Wisconsin, and is chair of the hospital's Antimicrobial Stewardship Committee. Dr. Redwood also teaches resident physicians and publishes research as a clinical adjunct professor for the UW Department of Family Medicine. Recent publications include Severe Sepsis Care in the Emergency Department and Antimicrobial Stewardship in the Emergency Department. Outside of work, he serves as a national counselor and past president of the Wisconsin chapter of the American College of Emergency Physicians. So now I'll go ahead and hand it over to Dr. Redwood.
Thank you, Annie. And welcome everyone to our webinar. You know, we've been pretty paternalistic thus far in terms of choosing topics. So we're choosing topics that are important to CMS, important to us, obviously important to patients. And so today we took your requests. Now, I think I may have bit off a little more than I can chew, to be honest. So tick-borne illnesses, COPD, and Clostridioides or CDI infections. But I tried to keep it narrow. I tried to really hit the high points. And this is really one of these webinars where I want you to ask questions. So if we have narrowed it too much or there's an aspect of this topic that you didn't feel was covered, please just chime in, type that into the comment bar, and we can do a little sidebar and talk about that topic specifically. I love tangents. I love to be interrupted. So I think it makes a much richer discussion when we have a back and forth because I need to know what your practice environment is like. I'm happy to provide the population health perspective. I'm happy to provide my own perspective from emergency department care, but the more that we talk about your specific questions, I think the more we'll get out of it. So without further ado, tick-borne illnesses, COPD, and CDI, current antimicrobial stewardship principles. This is me. I have no conflicts of interest to discuss. I'm usually telling you to use fewer drugs, so I'm sure the pharmaceutical companies are not a fan. And let's dive right into goals of our presentation today. You know, I have the schematic to the right, this Venn diagram, just to remind us that antimicrobial stewardship is for everyone. It's for frontline clinicians, it's for quality professionals, it's for infection preventionists, it's for nurses, it's for administrators. Really, there's a role in antimicrobial stewardship for everyone in the hospital. And the mantra of antimicrobial stewardship, I say it every time, is the 4 Ds. The right diagnosis, so we don't treat viruses with antibiotics, the right drug, the right duration, and the right dose. And so as we go through each of these topics today, we'll be talking about ways that we can choose maybe a shorter duration or a less broad spectrum drug agent or a dose that's more appropriate. First, we'll start with antimicrobial stewardship and tick-borne illnesses. We'll be talking a lot about Lyme disease, mainly because the recommendations for antibiotic prophylaxis, which is one of the key ways to spare antibiotics in this population, focus exclusively on Lyme disease, and we'll do a deep dive on that. We'll talk about antimicrobial stewardship and COPD, current resistant patterns, a common sense approach to the acute exacerbation of COPD, and then some new movement on GOLD criteria, which is empiric treatment, versus a procalcitonin-guided approach for moderate and severe COPD exacerbations. And I have some strong opinions on that, so I'm very happy to kind of dive into the specialist literature a little bit and then take a population health perspective on when antibiotics should be used in COPD exacerbations. And then I think the big gorilla in the room today is really CDI infections. So we had a sea change in terms of guidelines for CDI in 2018. IDSA really put out some comprehensive guidelines, and a lot has changed. Probably the biggest change is the new nucleic acid testing, so NAAT testing. I don't think it's a stretch to say that most of your hospitals are probably using it, and I think the cat kind of got out of the bag a little too soon on that one. And we can talk about ways to use your testing algorithm smartly to have fewer false positives and use antibiotics more wisely. We'll talk about the severity of CDI infections and how to triage your infection appropriately so that you choose the right antibiotic choice. There's been some big changes in the recommendations there. And then actually there's a new drug on the scene as well. So the metronidazole is sort of taking a back seat to fidaxomicin, and we'll talk about that change as well. So let's dive right in. Tick-borne illnesses and antibiotics. We have some nice gruesome pictures here. So that is the black-legged tick, also known as the deer tick above. And you see it in different phases of a blood meal. This is important, actually. We have this schematic hanging up in our ED. I hope you have it hanging up in your ED and clinic space as well. It's an easy Google search. But we'll talk about why that's important in terms of prophylaxis for Lyme disease. And then we have there some electron microscopy images of Borrelia burgdorferi, Lyme disease. Prophylaxis. You got to know if it's a deer tick. Simple as that. The picture on the right there has the different types of ticks that you're going to find in Wisconsin. One thing that we might not know initially, a dog tick is the same thing as a wood tick, and a black-legged tick is the same thing as a deer tick. So those are identical terms. And in terms of Lyme disease, it's really only carried by the deer tick, Excidioides. And in terms of prophylaxis, the CDC is exclusively recommending prophylaxis for deer tick exposures for concern for Lyme disease. So prophylaxis is a single dose of doxycycline, 200 milligrams, and you are only supposed to be offering that if it is a deer tick. And so a lot of times you'll have a patient come in and they'll say, oh no, it was a dog tick, or I'm sure it was a wood tick. If they know their tick, you're done right there. No need for prophylaxis. Or if they still have the tick attached or they bring it in a plastic bag and you can identify it as a wood tick, you can confidently say we do not need to have antimicrobial prophylaxis in this case. The other thing that matters is how engorged the tick is. So we'll do a deep dive on the CDC guidelines here. But if that tick has been attached for less than 36 hours, that is not sufficient time for it to have had a blood meal and to have spread Borrelia. And so if it's less than 36 hours, you do not need to prophylax. And so if we look at our deer ticks there on the bottom, unfed, 1.5 days, and 2 days, if you're in that 2-day, 3-day, 4-day range, you're greater than 36 hours, okay, now you can start thinking about prophylaxing. But if you're that unfed or 1.5 days, you can simply remove the ticks and not offer prophylaxis. Likewise, if it's too long, if it's after 72 hours, then prophylaxis is no longer indicated. That sounds funny, right? So a patient comes in and they have that 7-day engorged tick on them. The cat's kind of out of the bag. So if that tick was infected with Lyme disease, a prophylaxis strategy is no longer effective, and you actually have to wait for symptoms. So for that patient, you would say, hey, there's a chance that tick had Lyme disease. It's too late for prophylaxis. Let's wait and see if you develop body aches, headaches, a targetoid rash, something like that. So I'll really lay it down here with the epidemiology. The illnesses in Wisconsin that we're primarily concerned about are Lyme disease, anaplasmosis, and babesiosis. That is not to say that other tick-borne illnesses don't exist in Wisconsin. They certainly do, but they're rare, and the treatment approach is basically to wait for symptoms. We are really only prophylaxing for Lyme disease. And if you look at the top 3 here, they are all carried by a deer tick. So just another reason to really know the difference between a wood tick and a deer tick. If you practice clinically and you're kind of scratching your head, you're not sure if you could tell the difference between the two, I think that's an important thing to do, to really do that Google image search next time the tick comes in, to really scrutinize it, because having that level of sophistication is going to save your patients unneeded antibiotics. I'll read the full quote from the CDC here. I think it summarizes it great. Antibiotic treatment following a tick bite is not recommended as a means to prevent anaplasmosis, babesiosis, ehrlichiosis, Rocky Mountain spotted fever, or other rickettsial diseases. So for prophylaxis, it's Lyme disease only. The recommendation for all non-Lyme tick-borne illnesses is basically to watch and wait, and you are treating only if the patient has the rash, the fever, or other classic symptoms. So you're waiting for illness. I think we kind of get, as clinicians, sometimes a little misguided, assuming that all ticks bear illness. So sure, we're in a Lyme endemic region, but there are tons of ticks out there that just don't carry illness. So they get engorged, they have their blood meal, and you feel no symptoms. You simply remove the tick and go on from there. And so if it's a non-Lyme scenario, we're waiting for symptoms. Perfectly safe approach. these are the CDC heat maps in terms of where these diseases live in the U.S., and it just reinforces what we already said. Anaplasmosis, babesiosis, Lyme disease, you'll see those light up pretty clearly in Wisconsin. When you get to ehrlichiosis, it's pretty sparse in Wisconsin. And then all the other diseases, I didn't even put the heat maps on because Wisconsin is essentially clear. You'll see a few sporadic dots there. Obviously, you still want to have that on your radar in general. But 95% of the time, if you're focused on Lyme disease, babesiosis, and anaplasmosis, you've kind of covered your tick-borne illnesses for Wisconsin. So I'm not saying forget about all other disease. If they have a peripheral rash that's spreading towards the center, you want to think about Rocky Mountain spotted fever. If they come in with a Lone Star tick and a fever, you want to think about Rocky Mountain spotted fever. But by and large, we're talking really about Lyme disease in terms of prophylaxis, and then those top three in terms of treatment for disease. So this is my algorithm. This is how I approach a patient when they come in. This is a practical way to think about it. First, are you in a Lyme endemic area? So if you're listening in Wisconsin, automatically you're in a Lyme endemic area. If you're sneaking on the call from Colorado or Seattle, then you actually don't have to prophylax at all. You're not in a Lyme endemic area. For most people on this webinar, we are in a Lyme endemic area, so we proceed to step 2. Remove the tick. I think that's obvious. We're not going to leave a tick on our patient. And then try to identify the tick. If the exposure was not a deer tick, you're done. No prophylaxis indicated. If it was a deer tick, also known as a black-legged tick, or you're not sure what type of tick it is, then you can move on to step 4. Now you're trying to look for how long that tick was on. So oftentimes a patient will tell you, well, I went hiking yesterday. That was 24 hours ago. Great, you're done. Prophylaxis is not indicated if it was less than 36 hours. Or if it was more than 72 hours. So if they say, no, actually I was up in the North Woods a week ago, I just noticed a tick today, well, now the tick's engorged, the cat's kind of out of the bag, you would not prophylax and wait for symptoms. Just because that would be an unneeded dose of antibiotics. If the patient has Lyme disease already, it's not going to work. You're out of that incubation period. You basically have to see if they get full-borne illness and treat then. And then I said it already, but I'll say it again. The prophylaxis dose is 200 milligrams once. One dose, one single dose for adults, and then that's 4.4 milligrams per kilogram for children of any age if they're less than 45 kilograms. Now, we used to think that doxycycline in all children was at risk for staining the children's teeth gray. We now have excellent literature showing that that really doesn't happen for short courses of antibiotics. And the CDC actually has this Bright Smiles campaign to educate us. So they say, the research shows no evidence of tooth staining for short courses of doxycycline. And so you can really use doxycycline for rickettsial disease of any age. And that's important to know because it really is the gold standard for treatment. Summarizing here, Lyme endemic area, a deer tick or unknown, attachment greater than 36 hours and less than 72 hours, single dose of doxycycline. If you want to do a really quick QI project in your hospital, you can go down to your ED or your clinic, ask your clinicians to type doxycycline into the EHR and see if a prophylactic dose comes up. I would bet that in a lot of your hospitals, you will get a treatment dose coming up when you type in doxycycline. And if your clinician is not aware of these guidelines, or if they are busy and just hurrying through their orders, I think it happens very frequently that a patient gets a full course of doxycycline for prophylaxis, and that's a mistake. And so if you're looking at your system and you want to do something good, you can just have your IT professionals enter in prophylactic dose of doxycycline, 200 milligrams PO once. And so if a patient's in the ED, for example, they don't even need a prescription. That's a single administration in the ED, and they're done. They can go home. And so I think that's a way that we as clinicians sometimes get lazy, or maybe we're uninformed, and we can save our patients some unneeded antibiotics. We're wrapping up on Lyme disease here. I'm going to kind of leave a pregnant pause if anyone wants to type in any questions or concerns in the comment box. We can have a last-minute question on rickettsial illnesses before we move on to COPD. Actually, I got ahead of myself. I forgot about testing and treatment. That's great. So finally, for testing, these questions come up just all the time. When can we test? What test do we use? So if it's less than 1 month after exposure, you're going to start with IgM. IgM is your antigen that's going to come back quickly, and so you'll be able to see that probably while the patient's still in the ED or clinic. And if it's positive, it essentially confirms exposure, but you still want to send off confirmatory IgG and Western blot. If it's right after exposure, that test might come back as a false negative. So the patient could still have Lyme disease, but they just haven't, their serum IgM hasn't turned positive yet. And you're basically going to also acknowledge that these tests are not reliable if a patient has already had Lyme disease in tests, or Lyme disease in life, so you can get false positives if patients previously had Lyme disease. Really, practically speaking, I am usually treating Lyme disease based on classical symptoms. So if a patient comes in with a tick exposure and fever and headache, and especially a targetoid rash in the summertime, you can just say that's Lyme disease. You don't even need to test. For public health purposes, sometimes the health system will have automatic testing just for disease surveillance, but I will often treat Lyme disease without testing for it. In fact, I did that a couple of times just last week. The classic rash is there on the right. That's erythema migrans, and it is a disc-like rash. It does have a lot of variations on its appearance, and the CDC has sort of a buffet of different ways that erythema migrans can look. So if you have a rash, for example, that is a single rash on an extremity that doesn't have that target appearance, and you're thinking, hey, this sounds like Lyme disease, it probably is just an atypical rash, and so that is worth a Google search to look at the different types of erythema migrans rashes. The false positive that I always point out, though, is the local allergic reaction to a tick exposure. So this tick on the bottom right here, they're buried underneath the skin. That is not actually erythema migrans. That's just your local skin irritation from the tick actually biting into the skin, from those digestive juices, and so that would not be a Lyme disease rash. And you'll see that all the time. That's not Lyme disease. That's just local skin irritation. That patient, if that's a deer tick, would be a prime candidate for prophylaxis, but not necessarily for treatment, unless they already had headache and body aches. And then I think this is a major sea change. I don't know that this information is out there yet. We are now recommending doxycycline 100 milligrams BID for 10 days for Lyme disease. Now, if it is like full-blown Lyme and they have cardiac symptoms and arrhythmias, everything else, you can still go with the 21-day course. But by and large, I am treating for 10 days for Lyme disease. And you actually have to educate your patients about this too, because they'll say, well, my aunt had it and she had a 28-day course. Well, my son had it and he had a 21-day course. The courses for doxycycline keep shortening for Lyme disease, which is excellent for antimicrobial stewardship. So we're finding that 10 days of antibiotic exposure is effective, and we don't need to go quite as long as we used to in the past. And this may be something that you'll want to educate your fellow clinicians about as well. So if you're an emergency physician or a hospitalist or a family practice physician watching this webinar, next time you have your group meeting, just let them know. Did you guys know that the CDC is now recommending 10 days for Lyme disease? It really is a bit of a change, and I think it's something where the word is not yet out there. And then we have some second-line choices as well. So you will have that rare doxycycline allergy or intolerance to doxycycline. We're basically recommending cefuroxime or amoxicillin in those cases, and those are still the longer 14 to 20-day, one-day courses. Finally, chronic Lyme disease does not exist. Chronic Lyme disease does not exist. Chronic Lyme disease does not exist. It is not a clinical entity. There is not medical literature to support chronic Lyme disease. You can have persistent symptoms if you had a severe infection of Lyme disease that persists after you've already been treated for antibiotics, but there is not Borrelia in your system, and additional antibiotics will not help you. The reason the confusion is out there is because of Dr. Google, because of these, they're sort of like pseudo-patient organizations where patients will get together and say, we have chronic Lyme, the medical establishment isn't treating our disease, and it really is more of a psychosocial phenomena. And so we as clinicians really have to have the confidence to say, this is a mythical creature like the purple unicorn. There is no medical evidence among the infectious disease experts of the world that chronic Lyme disease exists. You do not need additional exposure to antibiotics. We will be giving you all of the risk with really no benefit. This can be a tough conversation to have. The patients will come in with websites that look like reputable sources. They will come in with literature that looks like peer-reviewed literature, but it simply doesn't exist. I don't know how to say it more frankly than that. And so basically, that final bullet point, prolonged antibiotic courses are ineffective and actually unsafe for patients with prolonged symptoms, is the take-home point here. And if you need a credible reference, the Lantos reference there at the bottom of the page, you can print out the article for the patients or for your colleagues, just to really hammer the point home. And great, it sounds like we have a question in the chat box, so I'm going to pause just one moment.
So the question is, what % of deer ticks in Wisconsin have Lyme's? Is co-infection common with Lyme ticks?
Co-infection for multiple rickettsial diseases. So I would say I would say I know it's less than 50%, but I don't have a number on you, and I think it's very geographic dependent. It's very region dependent, and so your local health department is probably keeping stats on that. You probably know if you're in a particular hotspot. So I think in my neck of the woods, we're sort of in south central Wisconsin, I believe it is much less than 50%. We see a lot of tick exposures where patients never get symptoms, and your local health department probably has the stats that you're looking for on that, but less than 50%. And in terms of co-infections, I don't know that we have that information because we're not routinely sending the titers for all infections, mainly because we're actually treating, right? So if your patient has a febrile illness after tick exposure, we're treating with doxycycline, which is the treatment for all of these infections. So I think that level of granularity is interesting from a public health standpoint, and it's interesting if you're a public health official and trying to decide what is the next epidemic in our area going to be. But from a practical clinical standpoint, we are treating all febrile tick illnesses with doxycycline. It should wipe out everything out there, and the main concern for us is Lyme disease. So, yeah, good question. Let's dive into COPD and antibiotics. COPD is a huge topic here, and I'm going to put a disclaimer from the start. The one topic I'm not going to dive into is whether patients should be on daily low-dose antibiotics for repeat COPD exacerbations. That is a topic that has so many nuances, and you have to dive so deep into the pulmonary literature that I'm going to punt it to our pulmonologists. What we will talk about is acute COPD exacerbation, which I think clinically is what most of us are encountering. So let's just make sure we're all on the same page about what COPD is, because it's really two clinical entities that got lumped together. So the first is emphysema. It's alveoli losing elasticity. The patients will present with shortness of breath, decreased breath sounds. They're quick to tire, and they have that cachectic appearance. So these are patients who are basically running a marathon every day of their life. And then the classic end-stage emphysema patient is there on the left. That would be the netter picture of an emphysematous man. And then chronic bronchitis is also a smoking-related disease. Obviously, there's other risk factors besides smoking, but largely tobacco use. And these patients will have swollen, inflamed airways. They're producing large amounts of mucus, and they almost present with these pseudo-pneumonia-type symptoms all the time. They always have this junky cough. They're always bringing something up in the tissue. They're short of breath, cyanotic. They have peripheral edema, and the classic explanation for this was your blue bloaters. So sort of more overweight patients who are hacking all the time, and they might come in with more sputum or a more pronounced cough than usual, but they have that cough almost every day of their life. And then a COPD exacerbation is a cough that increases in frequency and severity, sputum production that's increased in terms of either volume of sputum or the character of the sputum, and then increased shortness of breath. And these are the times we'll see our patients for an acute visit in clinic or in the ED. They'll say, hey, usually I'm short of breath under these circumstances, but I am more short of breath for X, Y, and Z reasons. Usually I can walk across the lawn and get the mail. Today I can only walk across the driveway. Usually I'm coughing up, clear sputum 2 times an hour. Today I'm coughing up clear sputum 10 times an hour, something like that. So it'll be baseline symptoms with an increase. Now, the Global Institute for Obstructive Lung Disease, or the GOLD Institute, has put out recommendations on how to treat COPD exacerbations for many decades, and they continue to recommend antibiotics for all moderate to severe COPD exacerbations. And we are going to challenge those criteria a little bit today. That is a niche specialist group, and there are dissenters within the pulmonologist community that say, actually, this is really not informed from a population health perspective. We are focused too much on individual care, and we are over-treating people with COPD exacerbation with antibiotics. And so the 2019 upgrade and update for these recommendations is actually pretty cool. They include the suggestion of considering a procalcitonin-guided approach on when to use antibiotics. And I'll use a quote from the pulmonologist literature here. Procalcitonin-guided antibiotic therapy in acute exacerbations of COPD is a promising and safe approach. And that's what we're going to advocate for here today. I think the literature for an antibiotic-sparing approach to COPD is clearly there. In fact, if you look at international guidelines, it's been there for over a decade. And the U.S., I think, is just a little bit behind on this, actually. And so we'll kind of review the world's literature here and make our recommendations from an antibiotic stewardship-informed perspective. If you look at what's actually triggering COPD exacerbations, It certainly is pneumonias. So a third to 50% of the time, bacterial pneumonia is triggering the COPD exacerbation. So I'm not saying that's rare. Actually, it's very frequent that pneumonia triggers the COPD exacerbation. But more frequently is viral infection. So anywhere between a half to 2/3 of the time. And then a lot of times the patients will come in with no infectious symptoms whatsoever. So they'll say, you know, my cousin's visiting and they brought their cats, and I have a known allergy to pet dander. Okay, that's not necessarily an infectious presentation. It's pretty clear why their COPD is acting up. Or tobacco use or tobacco exposure. I'm really stressed out. I've been down to 5 cigarettes a day, but the last 2 weeks I've been smoking 10 cigarettes a day. What about air pollution? Oh, sure. You know, I live next to a food processing plant, and they've really been cranking into overdrive. There's a lot of environmental exposure that's not, environmental smoke that's not really in the environment typically. If the patient comes in with a clearly non-infectious prodrome and they reverse easily with albuterol, I won't treat those patients with antibiotics at all, and I will not send a procalcitonin on them. We have to remember the harms of antibiotic use in COPD, and I think they're higher than the harms of the average patient. So these patients are at high risk for resistant organisms because they're receiving antibiotics so frequently. So if you're following GOLD criteria with your COPD patients, and they have 2 exacerbations a year over 20 years, that's 40 doses of azithromycin, if that's your drug of choice. And so you're just at very high risk for developing personal resistance to azithromycin or a multi-drug resistant organism. And we sort of see that in our biogram, in our Midwest biogram. You know, we had a previous webinar talking about azithromycin in the Midwest, and it's less than 50% effective for strep pneumonia. And so for the classic pneumonia, azithromycin isn't even effective anymore. And I think a lot of it is because of overuse, treating viruses, but also in COPD exacerbations. And the risk, of course, is that when you really do need that antibiotic, when you're now 75 years old or 80 years old, and you're in the ED with a severe or fulminant COPD exacerbation, and you are on death's doorstep, that our classic antibiotics won't help you anymore. That's the obvious concern. And then obviously, from an individual patient perspective, these antibiotics have a lot of side effects. They're QT prolonging agents if you're talking about levofloxacin or azithromycin. They might interact with your warfarin. They'll put you at risk for Clostridium difficile infection, especially fluoroquinolones. And so just sort of a high-risk population for repeated antibiotic exposures. This is an article I pulled from December 2018. It's under the headline News. Antibiotics should be restricted in COPD. I would not call this news. I think this is well established. It's only news here in the U.S. The NICE guidelines, NICE is the Population Health Institute in Britain, had a pretty clean quote here. It said, "The evidence shows that there are limited benefits for using antibiotics for managing acute exacerbations of COPD." And I couldn't agree more. We really need to work a little bit harder to confirm that there's a pneumonia before we expose these patients to antibiotics. And I'm glad that the pulmonary literature is starting to appreciate that more and actually put forth this procalcitonin-guided approach, which is what we're going to recommend today. And again, this is the classic tug of war, individual health versus population health. For the physicians in the group, most of us trained in a residency landscape where we were hyper-focused on individual health. Population health and public health took place in a governmental building across town where they're sort of doing their surveillance and making broad recommendations for statewide organizations. We are now bringing population health into the clinic. We are looking at our entire patient panel, and we are trying to think about how can we spare our hospital antibiotics, how can we spare our county antibiotics, how can we spare our region antibiotics. It's just a sea change. It's a different way of thinking about things. And now we're going to talk about how to do that in our COPD patients. So our denominator here is our patients with COPD. So here's what I do, and this is guideline informed. I use antibiotics if my patient is really sick, if they're septic, if they're ICU status, if they are severe symptoms, meaning they are on continuous albuterol and not getting better, if they're already on BiPAP or intubated. These are my patients who are now in critical condition and need antibiotics because of that, just in case. Who cares if it's a virus or not? Just in case we need to try to save this patient's life, it's worth exposing them to the harms of antibiotics, even if it's not a bacterial infection. I treat my patients with antibiotics in COPD exacerbation if there's clear evidence of pneumonia. That can be chest x-ray evidence, a new infiltrate. That can be CT evidence, infiltrate on CT or a new pleural effusion. Or it can be physical exam. If I hear frank crackles on exam that are not atelectasis, they're not clearing with deep inspiration, and the patient obviously has new fever or fever with change in sputum color, those would be concerns for pneumonia. And then special circumstances. So a patient is homeless, and I don't think I'm going to get a chance to follow up with them. Or a patient is going off into the woods for 10 days, and I'm not totally clinically clear if that's going to be a dangerous situation or not. But really, I'm trying to nail down the diagnosis of pneumonia before I expose my patients to unneeded antibiotics. Here's when I don't use antibiotics. If the patient has mild to moderate symptoms and they reverse well with beta agonists and a clear viral prodrome, so everybody in the house has the sniffles, my patient has the sniffles, everybody in the house has a sore throat, my patient has a sore throat, I listen to their lungs and they're clear, I'm not going to start that patient on antibiotics. I think I have a clear case for a viral infection, and my patient's smart. They're going to come back to me if they get worse, not better. If they develop those high fevers and productive cough and change in sputum color, they're going to come back to me. I think that's a very safe approach, and the international guidelines, especially the NICE guidelines out of Britain, would agree with that. And then the U.S. literature is really coming around to a procalcitonin-guided approach. So let's say it's ambiguous. This happens all the time. If you shoot enough chest x-rays on people with a COPD exacerbation, you are going to see some streak artifact. You're going to say, is that an infiltrate? I'm not really sure. Is that a little bit of a fusion between the lobes? I'm not really sure. Your radiologist might look at it and scratch their head as well. They'd say, you could call it pneumonia if the clinical presentation supports it. Well, send a lab test on them. Send a procalcitonin. If it's less than 0.5, that indicates a viral cause or a non-bacterial cause. And if it's greater than 0.5, that indicates a bacterial cause. And if it's greater than 2.0, that actually indicates that the patient's very sick and may be at risk for progression to sepsis. And so that lab is just very useful in this situation. And this is not an off-label recommendation. This is, as of 2017, this is FDA-approved use for procalcitonin to help for guidance in bacterial versus viral infections for lower respiratory tract infections. And so this is, I would say, this is not cutting edge anymore. This is fully vetted, fully approved, and I am very hopeful that the 2020 GOLD criteria will include this as a firm recommendation. Right now they have it as something you can consider. The pulmonology literature has already advocated for it, and I'm very hopeful it will be incorporated into those guidelines. And then finally, we talk a lot on these journal clubs about shorter course antibiotics. If you're using the antibiotics, there's strong literature for many different antibiotics that we can use shorter courses. Azithromycin, if you're still using that, is a short course already. That's 5 days. Obviously, in the Midwest, we have to take that with a grain of salt. It's not very effective against strep anymore. I am not a big advocate for fluoroquinolones, but if you are using a fluoroquinolone like levofloxacin, and that means you're concerned about a multi-drug resistant organism, you can do 5 days as opposed to 10. The literature is out on that. And then my antibiotic of choice would be doxycycline, a 5-day course of doxycycline BID, which is basically going to cover both strep and your atypicals, a relatively low side effect profile. We don't have a significant resistant pattern to it yet, and so it's just an ideal drug in this population from my standpoint. The grain of salt there is check your hospital biogram, okay? We have different bugs out there depending on your county, depending on your inpatient population, and so you want to really consult your biogram. Those recommendations may vary depending on your local biogram. Any questions on COPD before we move on to sort of the biggest topic of the day, CDI infections? I'm having to talk fast today. We have a lot to cover, so I hope you can all keep up.
Can you repeat the procalcitonin cutoff?
Oh, sure. So if you are thinking about getting procalcitonin in your hospital, have a rep come in and they will give you cards and charts on how to use this. And then if you already have it in your hospital, just go look at your lab because the measurements that I'm using, I believe they're based on deciliters, but basically less than 0.5 is likely non-bacterial infection. 0.5 to 2 is likely bacterial infection. Greater than 2 is at risk for progression to severe sepsis. And so those are the general cutoffs. You just want to check it with your labs because we use different reference ranges, and I want to make sure that the labs that the units that your lab is using are consistent with the units that my lab is using. So there are different companies producing procalcitonin, and your reference range may differ based on the company producing the test. But basically, yeah. Good question. All right. And you can always chime in with a question on a previous topic. That's totally allowed. There are no rules here. So this is your request today. Let's move on. So it used to be called Clostridium difficile. It's now called Clostridioides. And we are all calling it CDI infection, just to make sure we're on the same page. We have new guidelines for 2018, and I'm hopeful that this is new for some of you. So you'll be able to bring this back to your next Antimicrobial Stewardship Committee, or your next lab committee, or your next infection control committee, and say, hey, are we doing X, Y, and Z for CDI infection? So to understand CDI infection, we really have to understand testing, because there is a new test out there. It is the Nucleic Acid Amplification Test, or NAAT. It has high sensitivity and high specificity, and it is included in a lot of hospitals in something called the stool panel. The stool panel has basically blanket testing for everything from Campylobacter to Giardia to norovirus, and it includes CDI infection on there. And what I'm finding as I visit hospitals around the state is that we are using this test a little bit willy-nilly, meaning anyone with diarrhea, I'm probably overstating that, but a lot of patients with diarrhea are getting the NAAT testing. And if you're looking at your local CDI rates in your hospital and you're seeing an uptick in the last year or two, and you have this test, I think you're probably identifying carriers or non-toxigenic strains, patients who don't need to be treated. And so in Wisconsin, we've actually seen CDI rates sort of plateau, and in some areas even rise, and I wonder if we're getting inaccurate information from this test. So let's make sure that we understand how we're testing. At this chart, we're starting with ELISA for antigen, okay? So that's a GDH antigen, if you're a lab professional or you're very nerdy on CDI. This is a high sensitivity test. What does that mean? It means it's very good at ruling out CDI. So if this test is negative, you probably do not have CDI. However, it is not good at identifying carriers, and it is not good at identifying non-toxigenic strains. So in infants, for example, they will often have CDI in their colon, but it doesn't produce toxins, it does not produce disease, and it does not have to be treated. So if you have an infant and their mom comes in and says, or their dad, don't want to be sexist here, their parent comes in and says, hey, my kid has diarrhea, and they had a single diarrhea in their diaper, or a single loose stool in their diaper, that could just be from having too much formula or, whatever, just random. If that patient gets tested with ELISA for antigen, and it shows that they have CDI, that might be a non-toxigenic strain. That patient does not need antibiotics. Moving on to ELISA for toxin, for CDI A or B toxin, this is again a rapid test. This one has a high specificity. So this is actually good at ruling in the disease. It will tell you if it's a true positive, this patient likely has CDI, but it has poor sensitivity, so you're going to miss cases. So if you're relying exclusively on ELISA for toxin, there will be patients who actually have CDI infection, and you didn't pick it up because it's not sensitive enough. And then the problem with the PCR, with the NAAT test, is that it's not good at distinguishing between asymptomatic carriers or non-toxigenic carriers. And so it's kind of catching any CDI out there, and it's really overdiagnosing the disease. And then I have the cytotoxin assay on here. I'm not going to go into that test because that's more of an academic center test. A lot of community hospitals don't have access to that, and it's a send-out test anyways. It takes a few days to come back. And so in terms of a practical application of CDI testing, that unfortunately is not in our lexicon yet. If you have access to cytotoxin assay, that's wonderful, and you may want to incorporate that into your algorithm. But I want to try to keep things simple today and focus on the first three. IDSA says it well. The optimal diagnostic testing method for CDI is a subject of debate and depends on how carefully patients are selected for testing. We're going to say that, we're going to focus on that over and over again. How are you selecting your patients? So this is sort of the menu. And again, we're going to come in with a firm recommendation here, so don't get bogged down by the menu. But if you used the ELISA for the antigen alone, that would underdiagnose your COPD, or your CDI. So that's on the far left there. And then if you use, on the far right, if you use NAAT testing alone, that's going to overdiagnose your patients. And then there's sort of these three in the middle. There's these multi-step testing algorithms in the middle that says, we can get a little more specific and sensitive. We've used a multi-step test. And the one that we're really advocating for today is the center one. So you're going to start with antigen testing in carefully selected patients. We'll dive deep on that. If your antigen testing is negative, you've ruled out disease. If it's positive, you want to do a second test for the toxin. And if that's positive, then you've ruled in disease. And then if you have discrepancy, if your antigen is negative and your toxin is positive, then you use the nucleic acid test as a tiebreaker. And if that's negative, then it's a negative study, and if it's positive, it's a positive study. This is the idiot-proof way to test for CDI. So if you want to make sure that you're catching the maximum number of true positives and the minimum number of false positives, you would have your lab do this protocol, and then no matter what the clinicians are doing, whether they're screening appropriately or not, you're going to have some reasonably accurate testing. Even more sophisticated would be to make sure that your clinicians are doing good screening. What is good screening? We should only be testing these specimens for CDI infection. Patients who have new onset symptoms, patients who have 3 or more unformed stools in 24 hours, and patients who are not taking laxatives. Okay? So that is not the patient in the ED who comes in with a single episode of diarrhea. That is not the patient who had diarrhea yesterday, well-formed stool today, diarrhea tomorrow. That is not the patient who had C. diff earlier in the month and now their diarrhea has recurred. Okay? These are patients with new symptoms. I'm repeating for emphasis here. New symptoms, more than 3 unformed stools in 24 hours, and no laxative use. If you can say with certainty that every CDI sample that's being sent in your hospital meets these criteria, then you could use a strategy that relies on NAAT testing alone. The problem is it's not happening. I'll tell you what's happening in my ED. I'm happy to air out our dirty laundry. We are working exclusively on trying to get better at this, but patients are coming in with diarrhea, a stool sample is collected, and they're getting the stool panel sent. And the stool panel sure is testing for norovirus, it's testing for Campylobacter, but it's also testing for CDI across the board. Whether or not that diarrhea is new, whether or not the patient's on laxatives, whether or not the patient had a well-formed stool sent down to the lab, it's basically testing for CDI across the board. So the question is there an opportunity in your hospital to really put a policy in place where you're only testing patients who have screened for those 3 things? If you can't do that, which I think it's actually difficult to do. We have Homer Simpson saying, "See, it's difficult." It's difficult. If you can't do that, I think you need to do a 2-step approach. And the 2-step approach, as we mentioned, is start with the ELISA antigen. And if the ELISA antigen is negative and you have low suspicion for CDI, you're already done. That patient is now ruled out negative. If your patient tests negative and you have high suspicion for CDI, then you move on to toxin. If you test for toxin and they are both positive, then sure, your patient's positive. And then if you have a discrepancy there, you use NAAT as the tiebreaker. I know that's a lot to take in. I know these slides have a lot of text on it. So I want you just to bring this back to your next antimicrobial stewardship meeting or your next lab meeting and just sort of, bring in the slide content itself, and you can talk about what you want to do at your hospital. But this would be the IDSA guideline approach to multi-step CDI testing. And only if you can really ensure that your screening is accurate can you stick with an NAAT-only approach. And unfortunately, I think that's really hard to do. It's we're getting samples from lab or from the ED, we're getting them from the floor, we're getting them from clinic. Can you really ensure that all of your clinicians are using this test appropriately? And it's a pretty tall order, to be honest. So here's the summary. First of all, who should we test? You've heard it a few times already. This is the slide to bring to your meeting. So take a screenshot of my presentation. Absolutely share this with your infection preventionists, with your antimicrobial stewardship committee, with your clinicians. We should be testing only when patients have new onset symptoms, when they have greater than 3 unexplained or unformed stools within 24 hours, and when the patient is not on laxatives. We should not be testing if a patient has they're asymptomatic, but we're just retesting to see if it came back. We should not be testing if the patient had repeat tests during the same episode of diarrhea. So you had a CDI test early on in your hospital stay. The diarrhea is not getting better, so you test again. That's not really recommended. Or for infants, for example, neonates, anyone less than 12 months old with diarrhea should not be testing. And then when we do test, just to reiterate, NAAT alone is more likely to detect carriers unless you appropriately screen your patients. So if you see CDI rates raising at your hospital, that really might be what's happening. And then our preferred testing strategy is a 2-step approach, which we already kind of got into in the previous slide, goes into in depth. And then finally, we obviously can't cover this entire topic in a short webinar. So we're talking about using fewer antibiotics in CDI. But if your patient has radiographic evidence of pseudomembranous colitis, that's actually highly specific for CDI. Or if you're on endoscopy and you see pseudomembranous colitis with purulence, that's highly suggestive of CDI. So there are other ways to test for CDI in terms of radiographic findings or endoscopy findings. But for testing strategies, I think we laid it out there, the one-step versus two-step strategy. We have a question?
What if my lab only wants to do the GI panel and not separate ELISA antigen?
Yeah, totally. So getting sophisticated about so the question was, I hope you all heard it, the question was, what if lab is saying we're going to do NAAT only? Good population health is multidisciplinary. And so you've got to have a good relationship with your lab and your clinicians, and you've got to find the middle ground. Now, let's go to a theoretical hospital where lab has planted their flag and they said, we are not doing multi-step testing. It is not in the budget. I'm not going to put my technicians through it. NAAT only. That is a rock and a hard place. You have got to work your clinicians. You have got to make sure that screening is happening. And what I would actually do is look at your CDI cases and go and review those charts. And if you see patients who didn't have 3 unformed stools, or you're looking through their meds and they're on Miralax, or they had a previous CDI infection in the last month, then you can say, wow, this patient was inappropriately screened, and then where did they come from? Did they come from clinic? Did they come from the ED? How often is that happening? And if it's happening multiple times a week or multiple times a month, then you'll have to do a quality improvement project. You'll have to find a clinician champion and say, these are the guidelines. Can we appropriately screen our patients? And that stool panel is real. I mean, it's a bugaboo. That is out there, and it is being inappropriately used across the state. We see it over and over again. So that would be a tough spot. Let's do the opposite side of the spectrum. Let's say your clinicians are not going to do it. What are you talking about? The stool panel is so convenient. We are diagnosing patients confidently that they have the norovirus. We're able to send them home, and I really don't want to screen my patients in that way. I hope your clinicians are not saying that, but let's say that's what you're finding. Well, then you'd want to go to lab, right? And you say, listen, I cannot get my docs and APPs on board with this. Until we're able to get them on board with appropriate screening, can we do a multi-step testing where we start with antigen testing, ELISA for antigen, we move on to ELISA for toxin, and then we tie break with the NAAT test. And I'm hopeful that your lab is sympathetic to that. And then obviously you can try to do a middle ground. So if you know that all of your tests from the floor are screening appropriately, well, maybe you can do NAAT only if it's floor testing only. And then if it's coming from clinic or ED where you haven't been able to herd the cats yet, you can use a multi-step strategy. So that's kind of a hedging answer, I know, but it depends on your clinical environment. It depends on how multidisciplinary your antimicrobial stewardship committee is, and it depends on what you can actually make happen. And that's probably the challenge out there. If you need help from administration, show them your CDI rates. You can say, look, our CDI rates are raising, if they are, or they've plateaued. I think this is because of false positive testing. Will you help me out? And maybe you can have a hospital-wide discussion about CDI. Moving on, in the old days, meaning before 2018, before these new guidelines, we were treating with, we were escalating care, escalating antibiotic use, depending on if it was a mild to moderate infection, a severe infection, or a fulminant infection. We've actually changed that quite a bit. So now mild, moderate, and severe CDI are all treated the same way with oral therapy only. So if they're asymptomatic, if they don't have symptoms, if they have inconsistent diarrhea, if they have less than 3 unformed stools in a 24-hour period, if they're on laxatives, those patients are not being treated at all, obviously. If they have mild symptoms, if they have moderate symptoms, or if they have severe symptoms, and I'm not going to go through all this, you can just read these are the IDSA guidelines, but if they have any of these 3 categories, we're basically treating with oral therapy only, and we'll get into what oral therapy is. And then it's only the sickest of the sick, fulminant CDI, your ICU patients, your shock patients, your ileus patients, your hypotensive patients, your patients with megacolon on CT scan or endoscopy. Only these patients are going to receive both oral therapy and IV therapy. So again, if you are on your Antimicrobial Stewardship Committee and you haven't reviewed your CDI guidelines since 2018, it is time to review your guidelines. It's time to go back to those guidelines and take a look and see if you're still recommending IV and oral therapy for severe infections. And if you are, that is a chance to save your patients unneeded antimicrobial exposure. And Annie, am I correct that we sent out that algorithm with the webinar. So there was an excellent comprehensive algorithm that we sent out as a PDF with the webinar. It's not from Wisconsin, but it really is a model that you could use for your hospital. I used that algorithm to rewrite our home protocol at my hospital with my Antimicrobial Stewardship Committee. I hope you guys are on the line. Thank you for that. And then new drug recommendations this year. So fidaxomicin, I had not used this drug prior to 2018. This is a new drug for me. It has a 90% cure rate, and it has essentially replaced metronidazole. So metronidazole is largely out. We are only using metronidazole if it is an intravenous adjunct to fulminant CDI. So if you do have that severe CDI where the patient's in the ICU, you'll be using oral vancomycin and IV metronidazole. Or if the patient has obviously like an allergy to vancomycin or fidaxomicin, or if there's a shortage and vancomycin or fidaxomicin oral are not available. Otherwise, you'll be using fidaxomicin 200 milligrams twice daily for 10 days for mild, moderate, or severe CDI. So that is a new change. And that is interchangeable with oral vancomycin, so I know fidaxomicin is still on patent. If it's more cost-effective to use vancomycin, that's perfectly appropriate. The dosing is 125 milligrams 4 times daily for 10 days. So just a little bit more of a pill burden for patients. You might have a little bit of compliance issues compared to fidaxomicin, but both are excellent options. And then if you do have fulminant CDI, ICU, shock, hypotension, megacolon or ileus, that's when you're using oral vancomycin, a larger dose, 500 milligrams 4 times daily, and IV metronidazole, 500 milligrams every 8 hours. And then there are special protocols if you have recurrent CDI. I think that's outside the scope of the discussion today, but just know that there are special protocols for recurrent CDI. And then if a patient had CDI more than 3 times in a year, that's when you're starting to consider stool transplant. And so for a patient's third consecutive, or not consecutive, but third episode of CDI, the antibiotic strategy isn't working, you might want to think of the microbiota stool transplant. We have a question?
Given the cost, why would you use fidaxomicin for mild or moderate CDI?
Oh, I'm assuming you're asking why would I use fidaxomicin over metronidazole, and it's because it's more effective. If you're asking why I would use it over vancomycin, the only argument I could really make is that it's twice a day dosing instead of 4 times a day dosing. And so if your patient doesn't like taking pills or they're not inconsistently taking their pills, that would be a better option. But yeah, absolutely, use the cheaper drug. Again, all of these recommendations, these are national guideline recommendations, but you have to look at your home biogram. So your hospital should have a biogram, and if you don't have enough numbers to know how effective vancomycin is against CDI, then you'll have to talk to your local infectious disease specialist. But you want to be informed based on your local flora. So how effective is vanco versus fidaxomicin? They're both very effective drugs, and if all things are equal, absolutely go for the cheaper drug. I totally agree. I get no kickback from any pharmaceutical company, so I'm a big fan of using generics when at all possible. But obviously, the worst choice is the drug that your patient's not going to take. So if you have a patient who just can't handle that 4 times a day dosing, I guess that would be a compelling reason. So this is a summary. If you've just got 5 minutes to present at your next med staff meeting and you want to steal a screenshot of this slide, these are the high points. No prophylaxis for Lone Star ticks or dog/wood ticks. Dog and wood ticks are the same thing. If you don't know your ticks, look at C and D on the right there. That is the adult deer tick and the nymph deer tick. It is also known as a black-legged tick. You should really commit those to memory because you'll be looking at those ticks when your patients bring them in on a piece of toilet paper or in a plastic bag. No prophylaxis if the tick has not been attached for 36 hours or if it's unengorged. And no prophylaxis if it's more than 72 hours, so for that tick that's been on there for a week. That's a little bit less common of a scenario. That's probably more veterinary medicine. And then finally, if you do prophylax a single 200 milligram dose of doxycycline, I would be very surprised if all of your clinicians know this. This is a great opportunity to send out a quick email and say, hey, did you know it's a single dose? I have seen a lot of doxycycline prescriptions going out for prophylaxis. Why would you prescribe a prescription? It's a single tablet. You can give it in clinic in the ED or write a prescription for a single tab. And then finally, chronic Lyme disease does not exist. It's a tough conversation to have if your patient is convinced that it does exist because there is an internet misinformation campaign going on. But don't use the term chronic Lyme disease. Talk about persistent symptoms from a course of Lyme disease that's already been treated. For COPD, don't use antibiotics in acute exacerbation of COPD for mild symptoms and for symptoms that have a non-bacterial trigger. So we really want to solidify the diagnosis of pneumonia. If it's ambiguous or you're not sure, you can use procalcitonin to reinforce your decision. That is FDA approved, and there are now pulmonology literature proposing this approach, and I left a reference for that in your slide if you want to talk with your pulmonology team or your ICU team. And then if you are using antibiotics, you can err on the side of short courses of antibiotics and narrow spectrum. And above all narrow spectrum, I would say that the blanket practice of levofloxacin for COPD exacerbations is a bit tricky. We talked about on our last webinar, there's a DRIP calculator, D-R-I-P. You can look on MD-Calc and look up the DRIP calculator to see if your patient is at high risk from multi-drug resistant organisms. If they're not, then narrow spectrum is okay. And then finally for CDI, NAAT testing alone leads to overtreatment. It leads to overdiagnosis and overtreatment. And so that strategy is only applicable if you're screening appropriately. What does that mean? Greater than 3 loose stools in 24 hours, new onset symptoms, and no laxative use. That is the key to using that test appropriately. And if you can't establish that in your setting, then you might want to use a 2-step approach, which we outlined in this webinar. And then finally, for mild, moderate, and severe symptoms, we are treating them all the same with oral fidaxomicin or oral vancomycin. And with that, I'll open it up to final questions. We actually stayed under time. We actually obviously had a lot to address today, and so I thank you all for your time and patience.
A little bit of question and comment. This was a great talk. Do we have permission to use any of your slides at our local hospitals?
Yes. In quality improvement, we say steal like a sinner and share like a saint. These slides all have the WHA logo on them, and so just give credit to WHA, but I want you to download these, I want you to screenshot these, I want you to use any and all material. If you have an antimicrobial stewardship committee and you literally want to steal my slides and present the material on your own, I give you permission to do so. So I just want this information to get out there. I want people to look at the references for yourself and look at your local culture and make the changes. And so I think that's one of the strengths of quality improvement in Wisconsin is we are not proprietary here. We really want to focus on the patients. And when you stay patient-driven, you get better outcomes. Long answer, yes. And again, you guys have my email. It's bobby.redwood@gmail.com or rredwood@wha.org. I'm always available for individual questions. A lot of this requires some homework on your end, especially with CDI. You've got to go down to the lab, go down to whatever sub-basement the lab is in, and you can't send them a telegram via tube system. You got to go down and talk to your lab director and say, what are we doing for CDI? Do you think we're screening appropriately? And if not, is it possible to do a 2-step test? I think it's possible, but it probably will require a bit of QI work on your end in terms of getting it by med staff and proposing an alternate algorithm. But if you see your CDI rates going up, it's probably worth the legwork. All right, thank you, everyone. No more questions. Enjoy the beautiful weather out there. You've earned it after that heat wave. And good luck treating rickettsial diseases, COPD, and CDI in Wisconsin.
Thank you all for joining today's Journal Club. I will be emailing all of you a document with instructions on how to get your CME credit. I will also include the recording of the event, Bobby's PowerPoint slides, and another copy of the algorithm that he shared earlier. Please note that the CME portal will be active starting right after this event and will close on August 22nd. You cannot do it after, and we can't help you if you miss that deadline. Again, this is only offered to those of you who have been here for the live session. I will once again send the recording out as soon as we have it ready. If you have a need for any of the other HIN topics, please let us know and we'd be happy to put together education. Thank you, everyone, and have a great rest of the week.